Welcome to the Well-Being Manifesto podcast, where we translate science and experience into realistic and sustainable ways of living. In each episode, we offer clear and practical strategies to support all aspects of well-being that matter to you, whether in your home, your community, or place of work. The Well-Being Manifesto is hosted by Dr. Moain Dabrh and Dr. David Freeman, who have spent their careers advancing whole person care. Join us as we focus on real lives and real change, with less hype, more truth, better living.
Hello, everyone. Welcome, one and all, to the Well-Being Manifesto podcast. I am Moain of Dabrh.
And I'm Dave Freeman. Today's guest is Dr. Robert Pearl, physician leader, author, educator, and former CEO of the Preventative Medical Group, the nation's largest medical group. Dr. Pearl is the author of Mistreated, Uncaring, and most recently, ChatGPT MD, a book exploring different dimensions of how healthcare succeeds, fails, and can be reimagined. In the conversation today, we'll look at culture, cost, and the pandemic of chronic conditions, technology, and the future of care from personal to systemic levels. I learned just earlier that Dr. Pearl's books help go back to Doctors Without Borders. Dr. Pearl, we are honored and delighted to welcome you to the Well-Being Manifesto.
It's my pleasure to be here. I look forward to our conversation.
Great to have you. Thank you. Robert, I'd like to start with our audience getting to know you first as the person, and really beyond all these amazing accomplishments and titles that you hold and you have done, what are the formative experiences that brought you to the person you are today? So, and I know it's almost summarize your lifetime for us in just a couple of minutes, but just to get to know you more.
Sounds good. Probably the best place to start would be when I was a freshman in college. My intent when I went to school was to become a university professor. And in my freshman year, my mentor, a brilliant individual who went on to become the department chairman at Reed College, didn't get tenure. Not because he wasn't brilliant, he was absolutely brilliant, but because of his political views. And as strange as it sounds, I mean, I was naive, 17-year-old at the time. I wanted to go to something that had no politics. And I assumed that was medicine. It's life and death. How could politics affect science? So I went to medical school at Yale, and then I went to Stanford to do a residency in heart surgery with Norman Shumway, who was the first transplant surgeon in the United States. And then in my rotations that were there, I went to plastic surgery. I'd never been on a plastic surgical rotation. And I was taken to a mission trip in Mexico, where I got to see that in an hour and a half, you could change a person's life for the better. And that's what drove me into plastic surgery. I went on to become the CEO and had the chance to lead the organization in Kaiser Permanente, and then did that for 18 years. And now I'm having the chance to teach in the medical school and business school, and the opportunity to speak at conferences. And my goal when I was a surgeon was to improve the lives of 10,000 patients. Then as CEO, I wanted to improve the lives of 10 million Kaiser Permanente members across the United States. Now aiming for 300 million Americans and maybe even several billion around the world. We have a great opportunity in medicine today, actually with the introduction of generative AI, I think an opportunity that we've never had before to be able to save millions of lives and lower costs. And it couldn't be a more exciting time to be in medicine. That's what drives me every single day.
It's amazing. Yeah, that's beautiful message, Dr. Pearl. Could you speak to, I guess, what we call like the systemic or organizational lens in your book, Mistreated? You outline the dysfunction of current American healthcare, like fee-for-service incentives, fragmentation, and outdated IT. Many of those challenges persist. So, in your view, like if you were a systems architect that had a magic wand, what kind of things could you change that make real measurable impact on cost and care?
Well, you're absolutely right. The American healthcare system, it's 19th century cottage industry. It's fragmented with doctors scattered across the community. They could be across the street from the hospital and the information technology systems don't connect with each other. We're paid on a piecemeal basis. We call it fee for service. The more you do, the more you get paid. What did Charlie Munger say, the associated founder of Berkshire Hathaway, Warren Buffett? He said that, tell me your incentives, I'll tell you the outcomes you're going to get. And when you have a fee for service system, what you're going to get is more volume. You're not going to get more health. You're going to get more volume. You get more things done, more interventions. The technology we use is outdated. It's actually left over from the last century, although invented in 1834. It's called the fax machine. It's the way that doctors most commonly exchange information in the United States today. When I teach at the Stanford Graduate School of Business, I tell my students that. They ask me, what's a fax machine? They've never seen one. They don't even know what I'm talking about. And it's leaderless. Change just can't happen. There's no one here to make it occur. So what would I do? I would change each of those pieces. I would integrate care, create clinician groups working together, primary care, specialty care, inpatient care, outpatient care. I would pay those physician groups, not the insurance companies, the physician groups directly, and the hospital systems directly in terms of a capitated system, a single payment to take care of a population of patients. I would incentivize them to put in place the most modern technology. And right now, we'll talk about it later in the show, I'm sure. Generative AI to me is incredibly exciting. And I put in place a leadership structure, one capable of being able to create change. And I think that that type of approach would have the opportunity to be able to save far more lives than today, to keep the American nation healthy, to make healthcare once again affordable, easier to access, higher quality, with far fewer medical errors and much less physician burnout.
This is a great 30,000 view, because it's really you touched on all of these different elements that need to improve, and maybe I want to come closer from the aspect of there's the system and then there is the individual. You talked about the culture, that it is dated for both the systems and the individuals, and maybe start talking about not just even physicians, right? Because physicians, all clinicians, allied healthcare professionals that make up the system, that make it work despite all these challenges. You described that the culture of medicine has resisted change historically on some levels, even at the expense of better care for our patients and taking care of our own well-being as healthcare professionals. Reading your book, Uncaring, where you argue that this is deeply embedded in the culture, and you just touched on it. It can undermine prevention, it can undermine equity, it can undermine the well-being of the people who actually provide the service, caring for people. What has happened to us that we have come to this place, and what can we do as individuals in advocating to change the system?
I would switch the question around. Culture, these are the norms, the values that people have, and they last and get passed on from generation to generation. If you go to Italy versus Germany, the two are totally different. And they've been different for decades or centuries, and they'll be different for decades and centuries into the future. So understanding that culture is just what happens when we come to believe what we learn from our parents, from the people around us, from the societies in which we exist. And the culture of medicine was the right culture for the past. Now, what do I mean by that? What I mean by that is that the diseases that we took care of were acute problems. You had right lower quadrant pain. We diagnosed appendicitis. We took your appendix out, and you hopefully got better. You came in and you had pneumonia. We gave you an antibiotic and you got better. You broke your arm. We took you to the operating room. We fixed the fracture and you got better. These were acute problems. That's not American medicine today. American medicine today is chronic diseases. 70% of the visits come from chronic diseases. 70% of the cost. We're talking about diabetes. We're talking about hypertension. We're talking about chronic heart failure. And we do a poor job of controlling these diseases. Hypertension, the leading cause of strokes, we control maybe 60-65% of the time. Diabetes, which is the number one cause of kidney failure, of peripheral amputations, of heart attacks, We control less than half of the time, and we just accept that as being okay. And so that this is the culture. The culture is, what do we value? We value intervention. We value doing things that are major actions to patients. We don't value prevention of disease. We don't value lifestyle medicine and retention of health over time. And this is what I mean by the culture. And that's what has to change. We value the clinician's office rather than the patient at home. We value the hospital. These are left over from the last century and often from centuries before. And that's where I think the opportunities have to evolve.
This is still also a public perception, is that, which I can understand, is that we remain as a reactive system. We're not a proactive system. We don't go after the prevention, and we don't even reimburse or structure appropriately for it. And that's to your point, is that we're about interventions and how can we respond to a problem even before we interfere early and prevent it.
I mean, think about it. How much do we reward the cardiologist who unblocks the coronary arteries, and how little do we reward the primary care physician who prevents them from becoming occluded in the first place? And the economic system rewards the cardiologist 10 times more than the primary care physician, when every one of us as a patient would rather avoid the heart attack. I don't know anyone who wants to get a heart attack just so they can have it unblocked, the coronary artery. And yet there's very little in how we teach medical students and how they select residency and fellowship programs that support that. And that's the culture of medicine. It's the hierarchy. It's what you value. And we just don't value what Americans need more. I mean, think about it today. If someone walks into your office with pneumonia, you'll make a diagnosis, you give an antibiotic, you'll see him a couple of times and follow up, and that's it. As soon as you see a new patient with diabetes, you've got to schedule 4 visits for the next 50 years, 200 visits. That is why what we have is that we have a system that is overworking clinicians, where they're having to do more and more every day and driving out the burnout of our profession, and yet we cling to the old culture.
And Dr. Pearl, I love where you're going on that, the culture and the values, trying to change those antiquated historical practice. And I want to piggyback on that, the concept of these values and how it applies to what we saw in healthcare with physician burnout and moral injury. The pandemic sort of just, people were working sort of maximum overdrive. We saw burnout at record highs. And when you were CEO of Hazard Permanent, how do you sort of streamline, minimize bureaucracy? That you mentioned IT, like reducing documentation burdens. And I'm curious your perspective as a systems thinker, what you saw in healthcare that could probably apply to other industries as well, right? Making people feel valued, aligning the incentives in the right direction. Could you comment on that?
Sure, happy to talk about, when I was CEO and the things that we did. The first thing that we did is that there is no prior authorization. There's no second guessing the clinician. So each physician had the autonomy to do the things that he or she thought was best for the patient. Now, there was quality oversight, so that if you did something that was considered to be poor quality by your peers, then that would be brought up and looked at. There was certainly examination of variation in practice, because I'm a big believer that occasionally autonomy is essential, but most of the time there is a right way to take care of a patient. And so engaging those kinds of conversations and having engaged in it, to expect everyone to follow the right way to path driven by the clinician, not driven by some administrator. So that was the first thing I would say. The second thing is we invested very early in the electronic health record, way back right around the turn of the century, 2000, put in place the current system. In fact, we helped to develop the inpatient module for Epic at that particular time. But it's not just putting in place an electronic healthcare system, it's being able to use it. So as an example, we expected that every clinician, and I'm including the specialists, would be looking at whether the patient was up to date and all the preventive services that were required. And when they weren't, not that they could necessarily take care of it, but they could note it. I can tell hypertension. I may not know the right drug to give, but I can note it. I can call my colleague and I can prescribe it based upon my colleague's recommendations. So that's the second piece that sits there. A third piece that sits in there was really our ability to leverage integration. So what do I mean by that? If a patient was seeing a primary care physician and needed a specialty consultation, what do we do today in most of medicine? Go home, call the doctor, make an appointment. No, we actually had 2 telephones in the exam room, one for the patient, one for the primary care doctor, and the specialist would come in and provide the consultation there and then. And 40% of the time, they could totally resolve the problem immediately. Patient didn't even need to see the specialist anymore. 30% of the time, they couldn't necessarily resolve it, but they could start the workup. The neurologist would say, order an MRI and I'll see the patient as soon as it's done. And only 30% of the time did the patient need to be seen, which meant we could offer the patient a same-day appointment. Now think about how efficient that system is. 40% of the visits don't happen at all. 30% of them happen, but they save an extra visit. And 30% of the time, you can see the patient immediately rather than having to go home, call up, schedule a visit, prioritize all the things that happen in the specialty world of today that in most of medicine is backed up significantly.
I love that you said the integration, because I see that as like a bidirectional value alignment, right? The patient, the doctors are sort of part of this ecosystem, but the patient's at the center. I'm sorry, Moain, go ahead.
No, this is a great comment. I was going to build on what you started with earlier, because you said there is an opportunity for equity. We appreciate and thank our cardiologists, healthcare professionals, physicians, clinicians, but also that primary care and others should be equitable when it comes to reimbursement, support, and so forth. Then you talked about also 3 important points, amongst them the autonomy, integration, and there's a lot of research that supports that. I mean, I personally have been involved in research looking at how we bring the system to the patient, and that's the integration. One of the challenges that come up is that the scalability. So I'm curious about what pathways would you suggest to scale bringing the integration to the patient on different systems. Some systems may not have as much resources as other larger systems, for example. I'm curious about what would you suggest as pathways?
Well, I think it's hard to say using today's approach what can work, because if it's fragmented, you can't integrate it unless you actually bring people together and integrate it. And so I think that what we need to do is to create groups. So you can bring together different physicians. They don't have to all be in the same building. They don't have to all be under the same leadership structure necessarily, but they all have to work together in a harmonious type way. The individual doctor can't be capitated. Yes, groups like ChenMed, which are very excellent, are able to take capitation at a pure primary care level. But it works best when it's done at an entire systems level, because you could never do what I just described to you in the specialty arena. I'll give you another great example that we did. Dermatology. We put in teledermatology. If a patient came in and needed a referral to dermatology, they didn't get a referral to dermatology. They had an image taken, sent to dermatology that could be reviewed. And again, 70% of the time in dermatology, it can be solved. You can't do that if you're dealing with fee-for-service dermatology, because they need the patient to come into the office to drive the fee-for-service wheel to spin faster and faster. So what I would say is that they need to integrate in order to take capitation. Now, maybe there's a temporary spot where they can do something to be able to take a payment in the short term with a lot of parameters around it that are, well, if it happens to be in cardiology, it doesn't get charged. In neurology, it does, or vice versa. But I think really what we're looking at is an evolution in the healthcare system, which is why I'm so excited about the introduction of generative AI, because now you have a tool that's going to allow the different groups to connect with each other. And more significantly, now you have the tool to actually empower that patient to do it. I mean, we have wearable devices that are 99% accurate. Right across the street from where I teach the business school, there's the engineering school. They're inexpensive, they're fully reliable, and I dare you to show me a single doctor who's telling patients to wear them. Why not? Because they don't want 100 blood pressure readings every month. But now just imagine you have a generative AI tool that's able to take in this information. Bluetooth is how they'll ultimately do it. In the short run, you could type it in if you wanted to. It can do a first and second derivative calculation. And after 1 month, it can tell a patient, you're getting better or you're not getting better. What do we do in medicine today? You see someone with new hypertension. Oh, here's a medication, come back in 4 months. 4 months, they come back, it's elevated. What do we say? White coat syndrome. By the time you do something, it's a year later. No, at 1 month, we know whether they're getting better or not. And if they're getting better, great. I don't need to see you every 4 months. You're doing great. I have the data, the information analyzed. If you're not doing well, I'm going to change your medication right now. I don't need to see you again. This is just a different mindset that you're able to accomplish. And now imagine if instead of the doctor telling the patient you need your medication changed, the patient sends an email to the doctor saying, based upon this reading and attaches the graft, I would think I need to have my medication adjusted. The doctor saying, I agree or I don't agree. And if the physician agrees, here's the adjustment that we're going to make. Think about how empowering it is for the patient, how much more convenient it is, how much more efficient and effective it is, and by the way, how much lower cost it is.
Well, I think the last thing you spoke about, especially shared decision making, is that when you're bringing a person's preferences and values and you're telling them that they have that autonomy in making the decision, experiences with care improve drastically. And the point that you said also, one size doesn't fit all. The system needs almost gutting from the foundation in changing reimbursement models, equity in reimbursement, from reactive to proactive. And I think everyone agrees about these needed changes. I want to take the example of what can we leverage as some of what you started sharing, and because there are these system challenges and then there are the individual opportunities. Technology, for example, and you're an expert in this. For a long time, we resisted the idea of virtual appointments, and then something called the pandemic came through and told us, move over, you got to do it this way or nothing. And there is extensive research that a lot of groups, including our group, published about the value of minimizing the disruption on patients and bringing care to them so we can improve it. And we resisted. Now we have AI as an opportunity to improve it. Where do you see these opportunities starting to leverage AI to take on some of these challenges in the system and support the individuals?
The biggest change that I see is that we need to be able to segment patients based upon their likelihood of needing medical intervention. Today, we don't do that. I have 100 patients, and if I'm doing telemedicine and trying to follow them, I might do them sequentially. No, amongst 100 patients, there are 5 who need intense evaluation, maybe every day. And then I have maybe another 5 or 10 who need to have less intense, but still far more than otherwise. And I might have 30 patients who don't need it at all. Maybe once a year, just to have their overall assessments done and and blood pressure and blood studies ordered and things like that. So this is the opportunity to combine the two. A generative AI tool can tell the individual, how are you doing? Maybe you're healthy. How do you stay healthy? Maybe you have chronic disease. How are they being managed? How do problems evolve? And then be able to schedule telemedicine in response to that. And be able to, this is where, again, the integration comes in, because we're not talking about doctors being available 24/7. That doesn't make any sense at all. What we're talking about is groups of physicians having someone available. And how do they know who to connect with? That's where the generative AI tool starts to work very well. But I think it's far more than that. I was on a podcast maybe 9 months ago. And at the end of the show, we were off the air. The host said to me, my husband fell skiing 3 months ago. His arm was over his head. He slid down 100 feet. Dr. Pearl, you're a big skier and you're a doctor. What's happening? His shoulder still hurts and his arm doesn't work as well as the other side. And I said, I think I know exactly what he has, but do me a favor. You said you never used generative AI for medical uses. Put the information in place and see what it says, and then call me back and I'll tell you what I think it actually is. 5 days later, she calls back. She said, thank you so much. She said, we put the information into ChatGPT, and it said, number one, that he probably had a rotator cuff tear. Number two, he needed an MRI to establish the diagnosis. And number three, he should see a orthopedic surgeon because he almost definitely needed to have a procedure done. Now compare that to a Google search. When you click on lots of links and lots of information, you get 50 different reasons for shoulder pain, 50 more for why one arm doesn't work as well as the other side. And she said, we saw the doctor. He said, you probably have a rotator cuff tear. We didn't have to ask what the rotator cuff was. We knew exactly what it was. He said, I need to get an MRI. I didn't have to ask, is it really indicated? They knew exactly why it was getting done. And he said at the end of the procedure, if he had waited 3 more months, I probably could not have reattached the tendon to the bone where it was fully torn off. That is the real power that we're talking about. And in medicine, we don't know today. You know, you ask a clinician taking care of patients with diabetes, how well your patient's doing. Well, maybe there's a hemoglobin A1C that's telling them from last month. Maybe they can look up how it was compared to 6 months before and a year before. Why don't we have the technology for which this is a simple analytic process? Let us know that and structure our day. This is where the culture of medicine comes in again, because we don't want to be under the direction of a machine, in quotes. We're okay if it's an MRI or a CT, but we don't want it to be a computer, when in actuality, that's what would allow us to provide better care with, by the way, less time for most patients and a lot more time for the ones who are going to benefit the greatest.
I hope her husband is doing much better now. So thanks to Dr. Pearl
Oh,
and
yeah.
Dr. ChatGPT.
Exactly.
Yeah.
Pardon me, Dave. I want to just maybe extend this question to when you talked about the potential benefits, and this is still relatively a novel, new arena that we're delving into, the application and implication of AI in healthcare. There are opportunities for optimizing care, minimizing clerical burden, administrative burden, minimizing the risk of inequity, all of these things. So I want to flip to the other side, talking, and you brought this up in your book, ChatGPT, MD, the pitfalls and potential challenges with integrating AI into healthcare, for example, and other industries. What is your view on this?
Well, I think of them in terms of the general ones and the specific ones. The general ones are the same as almost every other application. You know, we got to worry about security and privacy. I always just say, is it better or worse than if you go into Google? I use Google because that's like Kleenex and Xerox, all the brand names. I don't really mean anything about the company per se, but a search engine. And I think the problems are less. Privacy. I mean, the model is a subscription model. It's not an advertising model. The algorithms are not based upon what's going to generate the most conflict and controversy. They're based upon whatever the literature might say. In terms of equity, which is a major area of my concern, I think it offers tremendous opportunities for 2 reasons. Number one, because it's been trained on bias and discrimination. Why? Because it's read the entire literature, everything on the internet. In fact, we probably should go back into that, because people often confuse AI as though it's a single entity, and it's not. Narrow AI tools, which are the 1,000 FDA-approved tools, they are built based upon taking 2 data sets. You take 10,000 mammograms, 5,000 show cancer, 5,000 are normal or benign. It finds maybe 50 different slight differences, not the 3, 4, or 5 we teach the heuristics of medical school. And then it assigns a probability factor, and it's able to diagnose about 10% better than radiologists. Generative AI, completely different. It's trained in the totality of the internet, every medical textbook, every journal article. It's read all the information on the problems that exist, and it's been, I'll say, it's been given the instructions necessary to be able to prioritize better information over less good information. Peer-reviewed articles are better than non-peer-reviewed. More recent, better than less recent. Ones from academic institutions are going to be better than ones from individual clinicians. And then it's going to be able to generate this answer to every problem that's out there. So a lot of the things that exist, I'd say, are accurate because it's a computer program. It can be hacked. It can have misinformation, but its chances become less. What are the biggest challenges with it? Well, in the short run, there are a lot of challenges. And I want to, again, for listeners and for viewers, this is a technology that's doubling in power every year. 5 years from now, it's going to be 32 times more powerful than today. Don't look at what exists right now. Look at the trend that's happening. Look at how much has improved from a year ago. When I wrote the book, I had ChatGPT as, in quotes, a co-author. I had to type in everything. Now I could dictate it or use visuals. It's multimodal right now. Its memory was very, very small. Now it's large. It was 18 months in arrear on information. Now it's up to date. We're going to see this doubling. It's like your car going as fast as an airplane in 5 years. You're not going to say to yourself, oh my gosh, how am I going to worry about speed bumps? You're going to be saying, how do I get from New York to Washington, D.C. in 1 hour? And what does that imply? How do we change that? The entire disruptive world, and yet we're still looking at it in this narrow framework. So what's the big problem going to be? Believe it or not, I think it may be the success of the tool, not in medicine so much, but in the rest of the world, because it's going to do a lot of things that humans do today. So-called artificial general intelligence, AGI, when an application will be as good or better than humans, that's estimated to be somewhere in 2 to 3 years. We're not talking no longer about 20 years. We're talking about a very short time period. It's said that GPT-5 is going to come out within a matter of months. I think it's going to revolutionize healthcare, and we're not ready. The big risk to me is we're not ready to take advantage of that, particularly as clinicians. And if we don't lead the way, you can be sure that for-profit companies will. And they're not going to prioritize the patient or the provider of care at the top of their agenda. They're going to prioritize shareholder value and profit return.
We're not ready on many levels, I would argue, because we're not ready even geopolitically from guidelines point of view. My concern about this quick evolution without a framework or guidelines is that it can, as much as helpful it's going to be, it may also create further inequity between different populations, between different geographical locations, but also, as you said, even between healthcare professionals and the system. So that I appreciate you touching on that.
So can I address that? Because you mentioned iniquity a couple of times, and it's an area of major focus of mine. I wrote about it both in Uncaring and in ChatGPT MD. The first thing I want to point out is that we as humans fail to see our failures. And what do I mean by that? 400,000 people die a year of misdiagnoses. Another 400,000 have permanent disability for misdiagnoses. 250,000 people, including my dad, I wrote about in Mistreated, die from preventable medical errors. 500,000 people die from unnecessary heart attacks, strokes, cancers, and kidney failures because we do a poor job of controlling chronic disease. And yet we don't look at all of that. And the inequity in healthcare today is massive. I was giving a talk in Rochester, New York, and 5 miles apart, there were 2 communities with a 15-year difference in life expectancy. We have to understand what exists today. If you try to get healthcare inside a socioeconomically challenged urban setting or in a rural setting, you're not getting the care anywhere near as good as it needs to be and can be. And I think that a generative AI tool will be a powerful force to restore equity. Now, it's not going to happen just by having it exist. And it probably, by the way, won't even happen in some fashion intrinsically. What we need to do is to create community centers. We need to be able to make sure that we have broadband access into the rural areas. And then we need to have the tools back behind it. But right now, today, particularly if you were working in an inner city, you're working a job or two, the offices are all closed during the day. You go to the ER, not because you want to go to the ER, you have no choice. Now you're going to create a choice. The people who can take the day off and go to the doctor, they're going to probably still go to the doctor. It's the people who don't have it today. And I would argue that the biggest problem when it comes to inequity is we don't see it. We don't talk about it. We don't see it as a problem. We think we're doing our job as well as it should be, and we're not. And this starts to be the tool. It's not the whole solution. You're still going to need to have more clinicians sitting in inner city areas. We're still going to have to solve the problem of running hospitals in rural areas when you only have an average daily census of 3 or 4 because there's not very many people. Those problems have to be addressed, but this will be a powerful tool that I believe can close half, at least, of the equity gap, whether you're talking about socioeconomic equity or you're talking about geographic equity.
I absolutely love that response. And I think, part of me as a historian looks back at the first Renaissance and we're like, what led to that explosion, right? The printing press, people had books, you were able to democratize knowledge. I mean, knowledge was powerful, right? I think Francis Bacon said knowledge is power, right? And it's very powerful. And I think we're seeing this exponential portion with generative AI because it's taking massive amounts of knowledge and it's making them at your fingertips. And I think it's been estimated about 5 billion out of 7 billion people have a smartphone now, right? And I think ChatGPT even created an 800 number on WhatsApp. So I have international students. We show them that one time. They're able to get answers on WhatsApp wherever they have Wi-Fi. So I'm optimistic to some degree. So
let me go beyond that if I could, because I think it's more than knowledge. I think what generative AI does, and I say generative AI, not the narrow AI, but generative AI, is it provides expertise. And I can't think, maybe you can as a physician, I can't think of a single technology that was ever introduced to increase patient expertise. Every tool that I can think of goes through the doctor to provide care, not that it wasn't designed to give better care. This will provide expertise. If you have a chronic disease today, you got to wait till you see the clinician to have the answer. Now you'll have expertise at managing it, understand how you're doing. Lifestyle changes, medication requirements, when you're having a crisis, that is expertise. Now you can find when you have that shoulder pain after skiing what's going on and what care you need in a way that's going to be clear, multi-language, multi-levels of education, unrelated to your socioeconomic status or educational background, because we can correct for all of that. That's going to be this opportunity that we now have. So it's expertise. It's beyond the printing press. Printing press was a great step forward. This is going to be true expertise. I mean, it's a tool that you can use to program a computer, even though you've never had an IT course. You can and you can create music, even though you don't play an instrument. Now you have the opportunity to be able to understand at a level that it would have taken years of education to be able to understand, to come up with an answer. We have to make sure it's accurate. We have to make sure the hallucinations disappear. I'm hoping that will happen in the next generation, or at least be minimized. But this is an opportunity for expertise far more than knowledge.
With a disclaimer, consult your healthcare experts.
Well, not
and
necessarily.
maybe soon that will change. But that's also the point where some might say, well, AI will never replace put in whatever profession you want, even including in healthcare. And I think that is a very optimistic statement because we still don't know. We hope that we can put guidelines and frameworks that will guide that process, but to replace or not, I think we're very cautiously optimistic.
A gentleman named Vinod Khosla was on my podcast, Fixing Healthcare. And Vinod said that, and I love this statement, he said that generative AI will not replace 80% of physicians, but it will replace 80% of what physicians do. Now, I think 80% is too high a number, but I think it will replace 30% of what we do today. And it will lead to better results as a consequence. I mean, as we said earlier in the show, the mistake is we think the way you lower healthcare costs is you deliver less care or with fewer people. No, the way you lower healthcare costs, you keep people healthy. And now, how does this tool allow us to accomplish that? It's going to take out a lot of the work that we do in chronic disease management, not by ignoring it, but by actually solving it for us. It's going to take care of patients with acute problems in the middle of the night on the weekends from coming to the ER because they can get more explicit information from this tool. I mean, think about a parent, the kid has 103 fever at night. It's 11 p.m. What do? Do you go to the ER where you know you'll wait at least an hour surrounded by people with infectious disease? Do you stay home? You click on Google, you see, oh, it could be meningitis. They'll be dead in the morning. What do? The application can take you through the steps. Is your child lying listless in bed, sweating, not moving, or is the child riding the bicycle around the living room? If it's the first one, call 911 right now. If it's the second one, go back to sleep. This is the expertise that is there. And I think you can say that's going to replace part of the ER. Yes, it probably will, in a very good way. We have a shortage of over 100,000 physicians today, and it's going to get worse across time. Primary care, particularly. How do we augment it? Between visits, we assume nothing happens. Things happen all the time. How do we evaluate patients with mental health issues who, they're not that depressed that we worry about suicide, but they could become? How do we have a tool to fill that in? How do we monitor patients between blood pressure checks or blood glucose measuring? These are the opportunities that exist today. And I'm going to be very, very blunt. We are blind to our failures. We don't see these as problems. But if you step back and look at it from a health perspective, this is where so many of the gaps and so many of the problems exist, particularly for people who have difficulty accessing it for either socioeconomic reasons, language reasons, or geographic reasons.
Love it. Yeah, and this is taking me back. I was thinking, what you were saying about the power of generative AI, and I was thinking, years ago we used to have a group we called the AHI, the Augmented Human Intelligence, and when I was a med student, we carried little pocketbooks, right, peripheral brains, right, in our pocket. We were looking at the iPhone, I think 15 has 16 million times more power than they sent the Apollo mission guys computer in space. And so literally it's incredible what people have in their pocket now to augment their abilities regardless of their background. So I love that message. So Robert, I wanted to shift gears and just to ask on what I'll call the horizon of hope. You've been candid about the system challenges, maybe the need for disruption, changing historic, and also optimistic about a potential. Given everything that we've discussed, burnout, cost, culture, and technology, are you still hopeful?
I am incredibly optimistic. I think I think we have the opportunity to enter medicine's golden age. I think we have the possibility of saving literally hundreds of thousands of lives every year, making care affordable for all Americans, and reducing burnout. If I have a concern, it's that we're not going to do the things that are necessary to accomplish it. The technology will not be the limiting factor. It's going to be the humans. It's going to be our ability, our willingness to be able to evolve the healthcare system, healthcare education to accomplish all of that. So no, it's exactly the opposite. As you say, I've written 3 books now, and the message was almost the same in all 3 of them because I could see what needed to happen. And by the way, I wasn't original. In 1932, there was a national commission that looked at the American healthcare system and came up with many of the same recommendations about integration and capitation. So this has been recognized for a long time, but we haven't had the tool. And I think generative AI, if used, if led by clinicians, has the opportunity now to accomplish that. I think we could have not just a life expectancy of 10 years more than today, very quickly, but a healthy life one for 10 years more from today if we apply this technology well. And we haven't had that. Life expectancy has been stagnant in the United States for the past 15 years, and COVID dropped it down, and we haven't even fully recovered from all of the COVID loss that sat in place. No, I could not be more excited about this tool. And I want to be clear to listeners. I'm not an enthusiast for all of technology. I was skeptical that Watson would work. Why? Because Watson was based upon the electronic health record. And I said, the electronic health record is so subjective. I see someone, I say, they have a pain of 5. You see someone, they say pain of 6. Whose patient has more pain? I don't know. You're 5, my 6, my patient's 5, your patient's 6. No, but the technology assumes that a 6 is worse than a 5. So we don't have those pieces. Generative AI, because it's built so differently, doesn't need to do that. It can provide the medical advice without having to learn from the electronic health record, because it's read the entire literature, knows all the information that is there. I think we could be entering the golden age of American medicine and global medicine, by the way, because our problems are no different than the rest of the world, because they all have the same limitations in the system. But if we don't take the lead, then I am pessimistic, because I don't think that the companies, publicly traded, high for profit, are going to make the right priorities sitting in place. And anything that's going to lower the cost of healthcare, which we think is really good for patients, they're going to think is very bad for their bottom line.
And just to follow on with that, what advice might you give to a young medical student stepping into medicine today who still want to believe in the power of healing and reform?
Well, the first thing I say to those students is you've come to the right place. So I still encourage everyone. I think being a clinician is the greatest job you can possibly have. But I'd back the question up if I could a little bit. This is the time, I think, for every clinician to becoming experienced using a generative AI tool. Download the free one if you don't want to pay $20 a month. I have like the $20 a month version. That's still, less than a latte every other week. So you can afford to do that. And put the information in place. If you're a clinician, you saw a patient today, put everything you learned about that patient in place and then find out, what's the diagnosis? What's the information? You have an x-ray. See how well it reads it. I'm not saying it's going to be perfect everywhere, but learn about it and not pretend you're the patient. Put your symptoms in place and ask yourself, if your patient knew this before they came. We're all afraid of Google Doc. Patient comes in with 100 printouts from various links, a third of which are very malicious in intent when they were downloaded in the first place. No, you're not going to see that, I don't think. But don't believe me. Go try the tool and then figure out how you might use it. When it comes to the young medical students, I wrote a Forbes piece on this as well, they're going to know the technology. What they haven't figured out is its application. So we've got to figure out, how do we better manage a patient with chronic disease, hypertension, diabetes, heart failure, with this tool, not today, but very, very soon. Imagine if you could have this tool measure ankle swelling, problems breathing when lying flat, difficulty walking upstairs in someone with chronic heart disease. And you knew 2 days before they were going to the ER that they had the problem and you could intervene. What would the difference be? So I think the innovative force, so I would say to the new next generation of doctors, you're the innovative force. Yeah, you can learn the old culture. You can learn all the ways that medicine used to be hierarchical, or you can be an innovator and lead the way, changing the way medicine is practiced, because now you have a technological tool that simply didn't exist before November 2022.
Bravo.
Thank you for sharing that. Well, Robert, I want to wrap up a wonderful conversation that could go for days, not just hours. Appreciate you, with some rapid fire questions from our audiences. So a quick question. So the first one, a book you return to often, professionally or personally?
I happen to personally love to read Malcolm Gladwell. And so I read almost a lot of his books many times. I want to understand things about the tipping point. How do we change culture? That's a tipping point opportunity that sits there in his first book by that same title. I want to understand aspects of what makes exceptionalism And where does it differ? And I think that exceptionalism in medicine, what makes a great doctor is not what the culture says that it is from my perspective. The great doctors of the past had amazing memory. They did great physical examination, and both are important, don't get me wrong, but not today. Today, we have a whole set of tools, whether it's going to be the CT and MRI and ultrasound for the, not to replace the physical exam, but to augment it in a very, very powerful way. But now how to use generative AI that sits there. So I often read a lot of his books, and I know him personally, and I enjoy him very much.
Great.
Love that.
Great choice. One habit or ritual that helps you stay grounded.
Oh, that's easy. I run every single day, 5 miles a day, 7 days a week, except when I'm traveling. And I shut my left brain off. I turn my right brain on, and almost every idea that I've ever had, I've gotten when I've created when I've been running or sleeping. By the way, so it's the same thing. But that's another story for the neurologist.
Well, I was going to say, I think Einstein called that combinatory play when he was playing the violin or an instrument. He got some of his physics ideas. So that's a brilliant answer.
Right. A leadership trait you admire but don't see enough in leaders currently, especially in healthcare.
That too is easy. It's valuing the people that you lead. Leader is never is any better than the people that they lead, and smart leaders understand that, respect that. Again, when I was the CEO in Kaiser Permanente, there was a major economic downturn. You may remember 2008, 2009, and there was a lot of call for us to lay people off. I said, no, we're not going to lay people off. You lay people off, they lose a job, they lose their home, they lose their income. And by the way, we're just going to hire them back anyway in 2 years when the economy turns around. I said, this is a chance to get flexibility. Things that otherwise might not happen, now we're going to do it. We're not going to do it for ourselves, we're going to do it for each other. And I can tell you that 10 years later, people were still grateful and still talking about it. And so that's an opportunity that's there. I don't want to say that I did it perfectly. I certainly made my own set of mistakes. But I think overall in every leadership position, people undervalue the people whom they lead.
Thank you so much for your candor, your insight, your expertise, and all these thought-provoking ideas, and especially saying that change is not only possible, it is needed. It's not easy, it's not quick, but definitely essential. So whether it's through payment models, cultural shifts, or reform altogether, a digital transformation, I appreciate what you've offered with us today, and just really incredible ideas. So I appreciate you.
I'd add two things if I could. One is change is inevitable. The only question is, are we going to lead it, or is someone else going to do it? And if we don't lead it, then we should be willing to accept the consequences, which I guarantee to folks will be worse than anything that happens if we lead it at all. And the second thing is, if listeners and viewers want to have more information, they go to my website, robertpearlmd.com, where there's a lot of articles and a lot of information on all the topics that we've covered. Thank you so much for having me as a guest today.
Wonderful. Thank you for your time, and for our listeners and viewers. If this conversation resonated with you, and I think it will, explore Dr. Pearl's work and his website, his books. Uncaring is a book that I've really not only enjoyed reading, it was also one opportunity that I first connected with Robert directly. So thank you so much for your passionate perspective on what medicine is and what it should become or be. Until next time, from Dave and I, inward with courage and outward with compassion.
Thank you for joining the Well-Being Manifesto podcast. Be sure to subscribe, like, and leave us a comment or review. To learn more about this discussion, visit thewellbeingmanifesto.com. And remember, inward with courage, outward with compassion.